Assalamu alaikum. This is lecture 6 of embryology. We are going to talk about the development of the tongue. The tongue appears in the embryo about approximately 4 weeks of age. The anterior two-thirds of the tongue forms from median and lateral tongue buds that arise from the floor of the first pharyngeal arch. The posterior third of the tongue arise as swellings from the floor of the third and fourth pharyngeal arches that overgrow the second arch, then fuses with the anterior two-thirds of the tongue. The line of fusion of these two parts of the tongue will be indicated by the terminal sulcus. Now, we are going to talk about nerve supply. The anterior two-thirds of the tongue, including the mucosa, it's supplied by the lingual branch of the mandibular nerve. Except for the test fibers of the taste buds, they are innervated by the chordotympanic branch of the facial nerve, whereas the innervation of the posterior third mucosa is supplied by the glossopharyngeal nerve. All tongue muscles, intrinsic and extrinsic, they are supplied by the hypoglossal nerve. Now, this picture shows the parts of the tongue and its innervation. As you can see here, this is the anterior two-thirds of the tongue formed from the median and two lateral swellings. They merge together form the anterior two-thirds of the tongue. As you see, all arise from the first pharyngeal arch. The posterior third of the tongue arise from swellings that are originated from the third and fourth. This will grow and cover the second pharyngeal arch, fuses with the anterior two-thirds, forming the tongue organ. The innervation, as we mentioned before, anterior two-thirds is innervated by the lingual branch of the trigeminal nerve, except for the taste buds are innervated by the chordotympanic branch of the facial nerve. Glossopharyngeal nerve is responsible for the sensory innervation of the posterior third of the tongue, and all the muscles are innervated by the hypoglossal nerve. This slide shows a condition named macroglossia, which is a congenital anomaly that arises during development of the tongue. Could be associated with other conditions including Down syndrome and acromegaly. The treatment is dependent about the cause, as you can see in this picture. Microglossia, here you can see that the size of the tongue is very small. This causes difficulties related to speech and swallowing. There is no treatment for this condition. Now, ankylosing or the tongue tie. You can see that the lingual frenum is short, less than 2 centimeters. This causes difficulties or limits the movement of the tongue during speech and feeding. The most common form of ankylosing is when the frenum is attached to the tip of the tongue. Thyroid gland. The thyroid gland appears as an epithelial proliferation at a point later indicated by the foramen cecum. The foramen cecum is located at the terminal sulcus that we mentioned before, which separates between the two-thirds of the tongue from the posterior one-third of the tongue. Then subsequently, this thyroid descends in front of the pharyngeal gut as a bilobed diverticulum, and during this migration, the thyroid remains connected to the tongue by a narrow canal, the thyroglossal duct. This duct will disappear later. This picture shows the migratory pathway of the thyroid gland until it reaches its final position. The thyroglossal cyst, which is a cystic remnant of the thyroglossal duct. Although approximately 50% of these cysts are close to or just inferior to the body of the hyoid bone, they may also be found at the base of the tongue or close to the thyroid cartilage. Sometimes the thyroglossal cyst is connected to the outside by a fistular canal, the thyroglossal fistula. Such fistula usually arises secondarily after rupture of the cyst but may be present at birth. This picture shows the size that could be where the thyroglossal cyst may appear across the migratory pathway of the thyroid gland. Could be even at the base of the tongue or here in the front of the hyoid bone or below the hyoid bone or even in the final position. Here is the clinical picture of a thyroglossal cyst. Now we are going to talk about the development of the face. Development of the face occurs mainly between 5 and 8 weeks of the embryonic development. The mandible is the first to form. The facial proportions develop during fetal period. During infancy and childhood, following development of teeth and paranasal sinuses, the facial skeleton increases in size and contributes to the definitive shape of the face. Early in the 4th week of embryogenesis, 5 primordial swellings appear and around the stomodium. This is the stomodium, which is the primitive mouth, separated from the alimentary canal by oropharyngeal membrane, which ruptures later, and there will be a connection between the mouth and the rest of the digestive system. These swellings include the frontonasal prominence, 2 maxillary prominences, and 2 mandibular prominences. By the end of the 4th week, bilateral oval-shaped ectodermal thickenings called the nasal placots appear on each side of the lower part of the frontonasal prominence. These nasal placots are the primordia of the nose and nasal cavities. Mesenchymal thickenings mesenchymal cells proliferate at the margin of the placots and produce horseshoe-shaped swellings around these. The sides of each swelling called medial and lateral nasal prominences. These are the medial, this other one side, and this is the lateral nasal swellings. This is the primitive oral cavity or the stomodium. The maxillary prominences continue to increase in size. Laterally, they merge with the maxilla, with the mandible, forming the cheek. This is the maxillary process merging with the mandible, forming the cheek. Whereas medially, this maxillary process on both sides compress the medium here, as you see here. This is the maxillary process growing and pushing the medial and lateral nasal prominences toward the midline until these 2 medial nasal prominences fuse together at the midline, and finally with these medial nasal prominences, the fusion, the upper lip will develop. The medial nasal swellings enlarge, grow medially and merge with each other in the midline to form a structure known as the intermaxillary segment. This is the intermaxillary segment. This structure, which is the intermaxillary segment, gives certain derivatives, which are the philtrum of the lip, and the premaxillary part of the maxilla that bears the four incisors and associated gums, and the primary palate. So these are the parts of the intermaxillary segment. Then the mesenchyme from the first and second pairs of the pharyngeal arches invade the facial prominences and give rise to the muscles of mastication and muscles of facial expression, respectively. The facial prominences also give the bones of the facial skeleton. Now, derivatives of the facial component. The frontonasal prominence forms the forehead and the bridge of the nose, frontal and nasal bones. The maxillary prominences form the upper cheek regions, most of the upper lip, maxilla, zygomatic bone, secondary palate. The mandibular prominences fuse and form the chin, lower lip, cheek region, also the mandible. The lateral nasal prominence form the ala of the nose. The medial nasal prominence fuse and form the intermaxillary segment, as we mentioned before. Now, development of the nasal cavity. With the formation of the medial and lateral nasal prominences, the nasal placals lie in the floor of a depression called the nasal pit on both sides. By the end of the 6th week, nasal pits deepen and form nasal sacs. Each nasal sac grows dorsocaudally, ventral to the developing brain. This also shows the nasal sac. Initially, the nasal sacs are separated from the oral cavity by the oronasal membrane. This membrane, as you can see, separating the nasal sacs from the oral cavity. The oronasal membrane, this one, ruptures by the 7th week, communicating the primitive nasal cavity with the oral cavity. As you can see here, beginning of rupture of this membrane. So this is the nasal cavity, will be connected to the oral cavity after rupture of this membrane. This is the beginning of the primary palate. These communications are called primitive choana. Here you can see that the nasal cavity is connected to the oral cavity. This site is named the primitive choana, located posterior to the heart, to the primary palate. This is the primary palate. Posterior to it is the primary choana. After development of the secondary palate, the choana changes position and becomes located at the junction of the nasal cavity and the pharynx. Here, this is the site of the definitive choana. The nasal septum develops as a downgrowth from the internal parts of the merged medial nasal prominences, fuses with the palatine process superior to the heart palate primordium. The nasolacrimal duct develops as a rod-like thickening of the ectoderm in the floor of the nasolacrimal groove. This cord gets canalized to form the nasolacrimal duct. The cranial end of this duct expands to form the lacrimal sac, while the caudal end opens into the inferior meatus of the nasal cavity. The duct usually becomes completely patent only after birth. Failure of complete canalization of this duct leads to atresia of the duct. Palatogenesis means development of the palates begins at the end of the 5th week. gets completed at about 12th week of age. The palate develops from two primordia, primary palate and secondary palate. The primary palate begins development early in the 6th week from the deep part of the intermaxillary segment as median palatine process. Lies behind the premaxillary part of the maxilla. Fuses with the developing secondary palate. Here is the primordia of the primary palate. It will be fused with the hard palate later on. This picture shows analytical sites of the primary palate, and this is the secondary palate. This is the line that separates between them. This is imaginary line, of course. The secondary palate primordia of the heart is the primordia of heart and secondary as soft palate. It's composed of bond part and soft part. Begins to develop early in the 6th week from the maxillar processes as lateral palatine process. In the beginning, the lateral palatine processes or shells project inferior medially on each side of the tongue. This one, and this is the other side. With the development of the jaws, the tongue moves inferiorly, as you can see here. The lateral palatine processes elongate and ascend to a horizontal position above the tongue. Here, the palatine shelves, they were in the vertical position on each side of the tongue. Later on, the tongue will take a lower position, so these two shelves are elevated, taking their horizontal position. They grow toward each other, fuse, and forming the secondary palate. Gradually, the lateral palatine processes, as I mentioned before, grow medially and fuse in the median plane. Here, as you can see, there is complete diffusion between two halves of the palate. Also fuses posteriorly with the posterior part of the primary palate. This is the primary palate. There is a line of fusion between the primary palate and the hard secondary palate. Also, there is diffusion between the hard palate and the nasal septum. Some anomalies related to the face, nose, and palate. Facial clefts in general means failure of the embryonic facial prominences to fuse properly. Lead to difficulty in breathing, feeding, sucking, swallowing, and speech. Could be unilateral, bilateral, may involve lips only, cleft lip, palate only, cleft palate, lip and palate, region of the nasolacrimal groove. The median cleft lip, as you can see, here is the median cleft lip, results from failure of the medial nasal prominences to merge and form the intermaxillary segment. The unilateral cleft lip results from failure of the maxillary prominences to merge with the medial nasal prominences on the affected side. Bilateral cleft lip results due to failure of the maxillary prominences to meet and unit with the medial nasal prominences on both sides. Here's one, and this is the second one. Oblique facial cleft results from the failure of the maxillary prominence to fuse with the lateral nasal prominence. Cleft palate leaves the nasal and oral cavity connected. You can see the nose and the mouth are connected, result in nursing problem of the newborn. Also, it could maybe anterior posterior to the incisor foramen. Unilateral, bilateral, could be isolated or associated with the cleft lip. This shows different types of clefts. Here, this is the normal condition. Here you can see there is a unilateral cleft lip. The cleft here involves the lip and side of the primary palate. You can see this is a severe condition because it involves bilateral cleft lip and primary palate. You can see here the primary palate is normal, lips are normal, whereas there is a cleft inside the mouth between the two parts of the secondary palate. Here the cleft extends from the lip, jaws and the secondary palate, and you can see that the nasal septum appears here clearly. Thank you and good luck.